No any.
Yeah, I'm just sharing. You able to see the screen?
Yes, we are able to see the screen, but we are waiting for the pediatrician. Yeah, please come first. Yes, sir. Please continue.
अभी कितने लोग आ गए धनश्री?
3
आए हैं ना?
Abhilasha, Jugal and Nilesh. Sorry, Dharti. अल्फिया आ रही है तो मोबाइल से कनेक्ट तो किया हुआ है.
हाँ बस ठीक है, मोबाइल से कनेक्ट किया हुआ तो मैं स्टार्ट करता हूँ, है ना?
आ गई.
Fine. So on that day we were discussing regarding, when there was a session when Dr. Rajiv sir was there. So there in that session of CLD, there was a mentioning about delayed cord clamping. So delayed cord clamping, he also even asked us that how many units in here for whom we are going to attend the deliveries, how many of them they are doing it. So I would say not many. Rarely somebody does delayed cord clamping, and this is in our NRP since 2015. Okay, so that is very important on part. I know, like when we go to the gynec and we just cannot dictate our terms, but this is to for fellows to keep this thing in mind that this is beneficial, and how it is beneficial we will just see in today's presentation, and why it should be done, that also we will discuss. But we should have in our mind that this is good thing and beneficial for the baby, and it has to be promoted. Number one. Number two, this can be a short note, and in NRP tables they can ask you regarding the delayed cord clamping. Many times they do ask because it is in the NRP instructions and the guidelines, and they recommend, NRP recommends delayed cord clamping for 60 seconds. That is for 1 minute for all babies except few cases that we will discuss today. And even for DNBs also, they can even ask in OSCE regarding delayed cord clamping, or they can have a short note on delayed cord clamping. No. So this is just a kind of thing, when there is an overflow, okay, there is an overflow. So that harms. So this is how the overflow occurs. Okay, so that harms you. So that is very important. Why we should be having a controlled flow from placenta towards the fetus. Number one. Number two, when the babies are being born, okay, and when we suddenly cut the cord, what are the things that can happen? So we will discuss this, and this answer I have already given you. Not many of us we practice this delayed cord clamping, and it should be done. Okay, so let's discuss one case scenario, and I think if it is interactive, it should be beneficial to everyone whosoever is sitting in the our conference hall, who has been logged in through the phones. They can give their comment on this. So this is a primey, 28 years old, who conceived with IVF. At present, when we are discussing this mother, the mother is 32 weeks of gestation, pregnant. Estimated weight of fetus is 1.2 kg. There is a history of PROM, prolonged rupture of membranes, for 2 days, and mother is having low grade fever, and she is being posted for LSCS. So you are called for a delivery, and the obstetrician is your spouse. It may or may not. In your discussion with obstetrician, what you should be doing it? Should you be asking for the provision of delayed cord clamping, or should you discourage it as this is a preterm baby and this is a high risk pregnancy, so you should avoid it, and there are high chances of postpartum hemorrhage, so we should avoid it. So what is your choice? Anyone from the group, from the conference hall? You can speak.
Sir, ask for a provision of delayed cord clamping.
Okay, so Sanjay has told ask for the provision of delayed cord clamping. Anybody else? Any of the residents?
Ask for the provision of delayed cord clamping.
Okay, Chandni has told this. Any of the residents? Your input? Anyone? Okay, fine. So yes, even though this is a preterm baby, there is a fever in the mother. Okay, so but if the baby, when the baby delivers and there is no birth asphyxia, okay, the baby is taking respiration, we should try to delay the cord clamping for at least 60 seconds. So the controversies and the myths regarding the delayed cord clamping is, what is the optimal time? Okay, what is the optimal time to delay the cord clamping? And this is there in the literature. Some people, they say we should allow the physiological cord to clamp, and that takes around 3 to 5 minutes, so that when the pulsations they are gone, blood flow has decreased, at that time we should cut the cord. And this is what has been followed in the olden times. But now the NRP recommends for term and preterm both 60 seconds of the delayed cord clamping. They have just come up with one number, okay, because it has to be uniformly followed. There's something in the chat. Okay. So so this has been so physiological cord clamping occurs around 3 to 5 minutes after the birth, when these pulsations are gone naturally by themselves. But NRP has to take care of all the scenarios. So that's why what they've done is they have come up with a number of 60 seconds, that is 1 minute, so that it can be followed uniformly in all gestation, in all conditions by everyone. Okay. Now, then the other thing was that if we delay the cord clamping, there will be the high chances of having PPH, that is postpartum hemorrhage, and hence the maternal mortality increases. But now all the data and everything has proven that this is a myth. It is a nature's provision to give extra amount of the blood from the mother side to the baby. Okay, and it is safe for both infant and maternal. For the mother, it is not that there is high chances of mortality in the mother. So as you must have, now the things have been changing, but this is what you even go for delivery. This is what is being followed by most of the health workers worldwide. What they do, they immediately clamp the cord as soon as the baby's head and body is delivered, and they pass on the baby as quickly as possible, isn't it? But this is not. If the baby is crying and there is no emergency or any specific condition, special condition, till that time you should not be hurrying up to clamp the cord and shift the baby from the mother to the pediatrician. Okay. So what happens is, resource poor setting are the main victims. Why they are main victims? Because when you have a resource limited settings, like in peripheries and all those places, already the people to which they are catering, they are socioeconomically of the lower status. So their nutrition is an issue. Anemia is a profound, especially in Indian scenarios, anemia is a profound condition in the mothers. So their maternal hemoglobin and blood is less. So less will be transferred to the baby. And if we take away that some time in which the extra amount of blood is going to the infant, to the newborn, by immediately clamping the cord, it profounds that. So that increases this. Okay. So that's why affluent classes may be less affected, but resource poor settings and lower socioeconomic status people, they are more affected with the practice of immediate cord clamping. And as you can see, this is a free means, cost-free means of very small store of irons, which can be useful, because you know that in first year of life, there will be a physiological anemia. And if the babies have good iron stores, that prevents that. And with infant anemia, you have impaired mental and motor development and mortality. This is the long-term outcomes of low hemoglobin, physiological anemia, adding on to that later in the life of that particular baby. So therefore, the delayed cord clamping is an effective strategy to reduce the anemia and improve the child survival. So that's why number 1 point. If we leave everything else, we will discuss this later also, but if we leave everything else and we just think about the iron reserves, extra blood that the baby is receiving during that 1 minute when the cord is clamped. So these are the benefits of extra transfer of blood from mother to baby in 1 minute. So in this, you can see the baby's term that is more than 37 weeks. When we delayed the cord clamping for 1 minute, what we have discussed, there are high early hemoglobin concentration. That is one thing. That is good because that will give extra blood to my baby. And as I told you, it increases the iron reserves up till 6 months. So it is not something that is just happening for initial period of time. It has a long-term effect on the health of my baby. And it has been clearly proven that there are no rates of difference of PPH, postpartum hemorrhage. No statistical difference. And the other thing is, which is very pronounced for most of the people, that because of this extra blood that goes in, what it does is causes polycythemia. And therefore, this polycythemia leads to this jaundice. Polycythemia leading to jaundice. And hence, there are chances that the babies in whom we do the delayed cord clamping, they will develop polycythemia, and then they will have a higher level of bilirubin. They will develop jaundice more as compared to the babies in whom we do not do the delayed cord clamping. But yes, there are slight chances of increased jaundice, but that is not in the pathological range. Number 1, we should remember that. Number 2, that it is not, when we study in a large population, we compile the data and do the analysis. What they have found is there is no statistical significant increase in jaundice. There was an increase, but it was not statistically significant. Number 2, whatever jaundice which was high, it was not of the dangerous level. So that clears our myths and worries. So that was regarding number 1, postpartum hemorrhage. So what we discussed, the postpartum hemorrhage does not increase with delayed cord clamping in the mother. And the next worry was that because of this extra hemoglobin, the babies may develop polycythemia and increased jaundice, but that apprehension of ours is also been relieved by the data what we have seen in the published literature. So now we just talk about a bit regarding the, okay, so Jaideep is asking the same benefit also in milking of the cord. We will come to that. Good question, Jaideep. So now we discuss a bit regarding the hemodynamics, that what hemodynamic benefit our baby, if it is at all it is there, can get with this. So this is a slide in which it shows that how much blood, okay, the placenta is having, and then how much blood the baby gets when we clamp the cord instead. Now the see, this is a time which by that time when the cord was clamped. So if we do instantly, it records around 15 seconds. That delay is there. So in that, most 90 ml of blood is there in the placenta, only 15 ml is being transferred in the baby. If we delay it for 60 seconds, what happens is 60 ml remains in the placenta, 45 ml goes to the baby. So you can see, if we do instant clamping of the cord, 15 ml of the blood the baby is getting. If we delay it for 1 minute, 45 ml, 3 times the blood the baby is getting by delaying the cord clamping by 1 minute. So that is really encouraging. So that is the amount of extra blood the baby has got in 1 minute. So in placentofetal circulation, total blood volume that goes from placenta towards the fetus is 120 ml per kg. 120 ml per kg. Okay. So what happens is delayed cord clamping, what it does, it allows more blood to leave the placenta and go to the baby, that we have already seen. Okay. So this is the blood volume and this is the time. Okay. This is the time when you delay the cord clamping. So we are talking about 1 minute delayed cord clamping. So if we delay the cord clamping, so that amount of blood will be, as I have told you, will be this much higher. Okay, this much higher. This much higher blood is going, volume is going to the baby. So what is the hemodynamics? Let's discuss that. Somebody has written milking is not recommended. Okay, that is again, this is not the thing. We will discuss regarding the milking also. Okay, fine. So now this is, in this diagram I will show you A and B are there. A is the physiological cord clamping after ventilation, and B is early cord clamping plus impaired ventilation. Physiological cord clamping. Physiological cord clamping, I told you, it is still the pulsations in the cord, they die away. So that takes around 3 to 5 minutes. So that is the physiological cord clamping after we have even started with the ventilation. In the B, what we have done is early cord clamping and the ventilation is being impaired. Let's discuss this one first. There is a physiological cord clamping after ventilation. So these are your lungs. So what is happening is spontaneous crying is there, and hence your onset of ventilation has started. If the baby does not cry, okay, and you have not intubated, there spontaneous crying is there, but if the lungs are not fully ventilated or there is no fully complete opening of the lung. So what we do, as per the flow chart of the NRP, neonatal resuscitation program, we start with the PPV. Okay, but now in this, you just imagine that you have started the PPV, because now we do have the cords for resuscitation with the intact cord. Intact cord, you can do the full resuscitation. The whole resuscitation trolley is been taken near to the mother. Okay, the star trolleys and all the different names, but they are very costly, but they are available. So now you see the positive pressure ventilation is started with intact umbilical cord in asphyxiated baby or in the preterm baby. So what will happen? So here is the placenta. Okay, in placenta you have umbilical artery and umbilical vein. Through umbilical vein, okay, through umbilical vein, through ductus venosus in inferior vena cava, the major of the chunk of the blood that comes to RA through this thing, PFO, it goes to LA. From LA, it goes to outside to the body. Okay, and then this is the blood that is being coming to, then from LV it is going to the body and everything. So this is the normal circulation. So now what happens with in a PPV? What happens is your lungs, they have opened up. Vacuum mismatch has decreased. The lung perfusion is better. So with that, your pulmonary vasodilatation occurs. Okay, hence more blood will go to the lungs. More blood going to the lung will increase the volume of blood in the lung, and hence increased volume of that blood, that will again, what happens to, goes to the LA, and that has become a preload for LV, and hence more of the blood is being pumped out, and then from there it can go to the body, and if the cord is intact, through body it goes to the umbilical artery to the placenta. Now suppose if this is the condition that your volume is less, so what happens, for 1 minute extra amount of blood will come in, and hence it will increase that volume. By ventilation, what you are doing is you are decreasing the right-sided pressures by pulmonary vasodilatation. With that pulmonary vasodilatation, more amount of blood coming from back through the placenta, more amount of blood going to the lungs, better oxygenation, and then more amount of blood coming from lungs to LA and then to LV. better preload for the LV, and hence better perfusion of the organs of the body and especially of the brain. So that is what is happening. Now suppose if you immediately clamp the cord, okay, and at that time the lungs are not ventilated. So what happens is your cord is being clamped, okay, even before the ventilation. Here what is happening, your ventilation and your delayed cord clamping, they are augmenting each other, okay, they are helping each other's physiological actions. But here what you have done is you have clamped the cord, and because when you start ventilation, you always start ventilation when gynec clamp the cord and give the baby to you, okay. So before even starting the ventilation, what we do, we clamp the cord. Now the baby has not cried or there is asphyxiation, okay, so there is no breathing effect. So the lungs are fluid filled, underventilated, okay. Now you have tried to open the lungs by doing PPV or by intubating. हेलो, हाँ हाँ हाँ, अरे मैं थोड़ा बिजी हूँ, ऑनलाइन मैं आपको कॉल करता हूँ. Okay, sorry. So what happens is that the vasodilatory effect which supposed to happen with all these mechanisms is not occurred very well. And so therefore less volume of the blood is available. That extra amount of blood has not come from the placenta, and over to that there is no vasodilation, effective vasodilation. So less amount of blood is going to the lungs, which are not fully opened up, so their oxygenation is a problem. And then your pulmonary venous return again will be less, decreased preload for the LV, and decreased amount of blood will go to the organs in the body. So therefore, as you can see by the width of these lines, the volume of blood is pretty good in this when you do not clamp the cord before starting the ventilation. But these lines are very thinned out here. It means a less amount of blood is being circulating in the system when you clamp the cord before starting the ventilation. So that's how your hemodynamics is affected with the delayed cord clamping. Okay, so this is our case. 32 years, Gravida 2, Para 1, living 1 mother, delivered by normal vaginal delivery, cried immediately, respiratory distress after birth, may need delivery room CPAP. Delayed cord clamping, yes, no?
Yes, sir.
Yes, ideally it has to be yes. The only thing is, as I told you, if the baby needs respiratory intervention, then it has to be, the positive pressure ventilation has to be provided to the baby before clamping the cord. That's what we have discussed in our hemodynamics slide, what we have just discussed. So that's why it is very important for us to have a kind of trolley or some arrangement in which we can start giving positive pressure ventilation to the babies with intact cord. So that is very important. Okay, now this. So again, this hemodynamics, I just wanted to re-emphasize, as we have discussed. So LV, what it does, stable LV output and cerebral blood flow will be good. Your brain perfusion is good. Okay. What are the preloads for LV? That is the umbilical venous return that is coming through your RA. From RA, it is going to LA through PFO, and that goes to your LV, and then from aorta it goes out. That is one thing. And the other thing is pulmonary venous return. And as everybody knows, with positive pressure ventilation and after the baby is born, because of the inflow of the air, opening of the lungs, the fluid squeezes out and your pulmonary vasculature decreases, so the blood flow will increase. So basically these things, this diagram is also explaining the same what we have discussed in the previous slide. So this division, how this division occurs, I will explain you once, because that comes in the fetal circulation and that will be a bit different from this. that is being very well explained, that why some of the blood, when it enters your RA, goes through PFO to LA, and some of the blood goes from RA to RV, and through the pulmonary artery, it goes to the lungs, and some of the blood shunts out through the ductus arteriosus. But the overall message is that blood moves, blood volume becomes better, lungs perfusion become better, therefore your oxygenation becomes better. With all these increased blood volumes, your preload of the LV is increased, and hence the blood volume that the body gets also increases. So again, so now why we delay cutting the baby's cord? One, it keeps the mother and babies together for bonding, so that bonding initially just after birth increases. Other thing, we have this, keeps the baby oxygenated while the baby learns to breathe. So till we start ventilation or baby starts ventilation by itself, the oxygenation in the tissues is being getting by the oxygenated blood from the mother. And baby receives full extra blood volume that supplies extra iron, maintains oxygen, and hence it causes the stem cells it gives the stem cells in the blood, transfer of the more stem cells from the placenta to the baby for healing. And the amount of blood, how much it transfers with the delay of 60 seconds, we have already discussed. Okay, and in evidence, it is there now in NRP, that is more than sufficient as evidence, because they have done the whole guidelines, studies, and everything has been done, and now they are recommended in NRP that it has to be delayed till 60 seconds. So that is more than sufficient as an evidence. Okay, so late cord clamping approximates 1 to 3 minutes after birth is recommended for all birth with initiating simultaneous essential newborn care. This is by the World Health Organization. But see, WHO has given a range. Okay, they have not specified, but NRP has given very specific time cut, 1 minute. So it is easy to follow for every baby, for everywhere. And what benefit it has, we have discussed that, and I will just try to re-emphasize it again. Higher birth weights, increased blood volume, and increased oxygen levels and nutrition. Increased blood cells, red blood cells, stem cells, and immune cells. So the immunity improves. Increased iron stores, and hence there is a decreased risk of anemia. And it has been proven in the studies there is a 50% reduction in risk of anemia. And this is very important, especially in resource limited countries or third world countries or developing countries. So this is in India, especially in the non-urban areas, this thing becomes very important. And we must be very clear that this blood is not cord blood. It is the baby's blood. Okay. So this is not the blood in the cord. This we have to keep in. This is the baby blood. When we ask mothers to give away cord blood, they are under an illusion. So this blood belongs to the baby, not the umbilical cord. So what this statement does, this particular statement, what it discourages, anyone? It discourages one thing we commonly see now in modern and hi-fi hospitals and all hospitals nowadays. Anybody? What this statement discourages? Fellows, any of your fellows? Have you heard of cord blood banking? Anyone?
Yes, sir.
Yes, sir. Yes,
Stem cell
Cord blood banking, isn't it?
yes,
So,
sir.
is it advisable, not advisable? Yes, no?
Sir, it is advisable.
Okay, why?
Sir, in future, if we may, in case we may require stem cells for any particular disease treatment in the siblings or any of the family members, it may be helpful.
Yeah, so it will be useful for the siblings and the family members. Okay, but instead of one family's got this thing, what we should encourage is, like we have, it should be a common bank. which can be used by whose HLA matches. It can be used by everyone, but not a family specific. The family specific, this cord stem banking, what we do is not scientifically a good thing, practice to follow. We should discourage this. If it is a common bank for everyone, that has to be encouraged. So that's why this statement is discouraging that umbilical cord stem cell banking, because one, it as for when you have to do this cord cell banking, what we do, so immediately they cut the cord and they take, and whatever the blood is there in the cord for the baby, they will take away for the sampling. So it is, what they're telling is, it is not the amount of, it is not the blood of the mother that has been taken for the sampling. It is the blood that is for the quota of the baby, for the baby which they are taking away. So that's why they discourage that. Okay. And so mean neonatal hemoglobin at birth, group A and group B. So this was in which there was no delayed cord clamping, in which there was a delayed cord clamping. You can see the difference of mean hemoglobin and the p-value 0.008. So that is statistically significant. And what they've done is they did what is this? Residents, only residents should tell. What is this? What I'm showing? Kya hai ye? Any one of you?
Sir, forest plot.
Good. So this is forest plot. Okay. So read this heading. Comparison between early versus delayed cord clamping. Okay. And then outcome is for that is transfused for anemia. So early versus late, and then they have seen the how much, like for how much transfusion was been done for anemia. So this is early and this is late. So what inference you can make out of this? This is early cord clamping. This is delayed cord clamping. Anyone? Okay. Any of the fellows? What are these symbols? What are these symbols? And what they represent? Anyone? Okay. So this is a forest plot and this is your diamond. So it is favoring that delayed cord clamping. Okay. The amount of transfusions which we needed for the anemia are less as compared to the, they were less as compared to the early cord clamping. So WHO recommendations are, in term or preterm, there is a strong recommendation that we should not clamp the cord less than 1 minute. Okay. And preterm babies require positive pressure ventilation. The cord should be clamped and cut to allow the effective ventilation to be performed. But these are conditional recommendations, because if we do not have the provision to give positive pressure ventilation while the cord is intact, then we should not be leaving the baby unventilated for 1 minute till the cord clamping has been done. So that's why they have written a conditional recommendation. Ideally, it has to be done as we have seen in the hemodynamics when we discuss hemodynamics, but because of this issue, it is a conditional recommendation. Newborn babies who do not breathe spontaneously after thorough drying should be stimulated before the cord clamping and initiate the positive pressure ventilation again if you have that provision. Okay. Late cord clamping is 1 to 3, like NRP recommends 1 minute for all the births while initiating simultaneous initial, like, you know, cleaning, drying the baby, and all those can be done on the, even for normal vaginal delivery, for normal term babies, it can be done on baby mother's tummy. And this is what now we even teach in NRPs. Early umbilical cord clamping less than 1 minute is not recommended unless the newborn is asphyxiated and needs to be moved. Okay. Only exception for early cord clamping is asphyxia. So in summary, the delayed cord clamping not less than 1 minute is recommended for improved maternal and infant health, nutrition and health. So that is now very clear in all recommendations by NRP and in WHO. Okay. As I told you, this been updated, the NRP guidelines were updated, and this was added into the guidelines from 2015, that is since last 7 years. So are we convinced? So why the things will prevent us after seeing all the evidence? Still we have some questions regarding delayed cord clamping. The people then ask, because of the increased volume overload and increased volume for the heart, and then it will increase pump out more volume. So can it lead to IVH in the preterm babies? Because of the high blood load to the system and polycythemia, because of this polycythemia, can it lead to NEC? High blood volume, can it lead to HSPDA and cardiac failure? With more congestive lungs, can it lead to CLD? And again, this point we have discussed, hyperbilirubinemia because of polycythemia and increased mortality. So all these things we are worried, because we have seen in hemodynamics that it will be more volume of the blood, more hemoglobin. But when again we, for these things, when we again see the evidence, and this is again a forest plot. So what we have seen, it was non-convincing, that it was not statistically significant, that it jaundice goes in favor of early and delayed cord clamping. So it is statistically not significant. The incidence is same in both the type of practices. Okay. Hyperbilirubinemia we have seen, that doubt we had. Then inotrope requirement. Again, it was not statistically significant. As you can see, the final diamond is crossing this line. So it is not so that your delayed cord clamping, you may have more inotropic requirement or shock. PDA again was more, even though it is not statistically significant, but you see a major chunk in early cord clamping side. So PDA is more of a problem in early cord clamping as compared to delayed cord clamping. So that again relieves our apprehension that because of the volume overload, the PDA will become more hemodynamically significant. Okay, yes, there is a slight trend on the increased side for IVH for delayed cord clamping, especially in ELBWs, babies less than 1 kg and 28 weeks. Rate of death is same in both the group. So there is no difference. So when it has to be done, so that why we have already discussed why it should be done. So we have discussed the pathophysiology, we discussed the hemodynamics, we discussed the evidence. Everything was in favor of delayed cord clamping. That was why. Now the next question is when it should be done. NRP and everybody has given the recommendations that at 1 minute. Okay, but physiologically we have seen that physiological cord clamping occurs 3 to 5 minutes, because cord clamping should be delayed for at least 3 minutes for the optimal volume of placental transfusion, regardless of the weight of the fetus. The grade of recommendation is weak. That was when we make our guidelines, we do a grading process. Okay, so grading, when we do the grading process, then the recommendations from that grading process become very strong. So what they have at that time, it was weak, but in the state of infant does not allow clamping delay of 3 minutes, aim for a delay of at least 60 seconds with the infant plates within the mother's leg. In 2006, it was a weak recommendation. But then now in 2005, after around 10 years, the evidence clearly showed and switched it over to the recommendations, strong recommendations by WHO and by NRP. So let's discuss this case. 38 years old, post-dated primary mother, fetal distress, MSL. Emergency LSC is done, did not cry immediately. Will you go for delayed cord clamping in this baby? Yes, no.
Yes, if a provision of resuscitation nearby
Yes,
mother.
if it is there, but if it is not there, that trolley is not there, then because of this birth asphyxia, it has to be deferred. Okay. Whenever there is an immediate neonatal required, the child, this is for the, so that was when, and which exceptions again is, there's a great debate, and in NRP also they have written two exceptions. One is birth asphyxia and one is multiple pregnancies, that is twins or triplets. Then also you can defer delayed cord clamping. So immediately when the baby is been born, so baby does not require any active, much higher assistance for the crying or for respiration. Then you put the child between the legs of the mother and start if needed. Otherwise, it does not need. That is for the normal babies. Just you clean the mouth, you drape the baby, clean the baby, and delay the cord clamping for 60 seconds. Other thing is, delayed cord clamping should be combined with the administration of oxytocin immediately after the delivery of the infant to reduce the mother loss in the third stage of labor. Okay, so this is what, why when this delayed cord clamping concept was being coined, so they were worried about PPH, postpartum hemorrhage of the mother. Okay, so now what they recommend is delayed cord clamping should be, as soon as you clamp the cord, you give oxytocin immediately to the mother. So this will reduce that chances of PPH. Adequate transfusion within +10 to -10 centimeters to nothing or more than. Okay. So this is basically, they try to see where to keep the baby. Okay, how it should be done, whether to keep the baby above the mother, below the mother, or at the level of the mother. So these are what they've done is, we have seen the amount of blood transfused from placenta to the mother when they keep the baby 10 centimeters above the mother till 10 centimeters below the mother. Okay, so nothing was much there. But when they did it for 40 centimeters above and below, so how much transfusion difference occurs with the difference in the height, 10 centimeter versus 40 centimeter, 10 centimeters versus 40 centimeters above and below. Okay, so then they have seen for how much time we should take and how much this thing we should do. So what they found is, so these were the guidelines which were informed after this. Delayed cord clamping should be considered in every infant born in a rescue resource poor settings, regardless of the gestation date. It has to be done. That we all agree. Delayed cord clamping should be combined with the administration of oxytocin immediately after the birth of the infant to reduce the maternal blood loss. Again, this is strong recommendation. Cord clamping should be delayed for at least 3 minutes. Now NRP tells 1 minute for optimal blood transfusion. It has not probably, it has, again, it is to be do it. When the state of the infant does not allow for delayed cord clamping, okay, then the birth asphyxia or this thing, then you can defer it. Put the baby at the mother's level, okay, just within the legs, and then keep the baby placed there, because there is no much difference if you increase the height till 40 or 10. So if you keep it at the mother's level or just below the mother's level within the legs of the mother and delay the cord clamp till 1 minute, you can achieve the same amount of blood transfusion from the placenta to the mother, and it is the recommendations. This is how it has been done. Okay, so this is how what I was telling, just in between the legs, just below the, just on the table, within the legs of the mother, you keep the baby. and delay the cord clamping till 60 seconds. So this is again the post and pre interventions regarding the timing and delay. So that was regarding that 1 minute. Okay. So if this benefits the babies, yes, immediate drying, delayed cord clamping, yes, immediate cord clamping and delayed drying and suction, no. Why? But this is common. This always help. You put the baby on the mother's tummy, delay the cord clamping for 1 minute. And if the baby does not require the suction, do not do the deep suctioning. Increase skin to skin contact and start breastfeeding immediately after clamping the cord and cleaning the baby, drying the baby and keeping it on the mother. Do not immediately cut the cord, shift the baby to the warmer, like take away the baby from the mother and start doing the suctioning if it is not required. So these things are not to be done, but they are common. These things are need to be done, and that is uncommon. So these main benefits and drawbacks we have already discussed. So when you have the delayed cord clamp, so the thing is we have to follow these practices. Okay, these practices need to be followed. Our science we need to apply by ourselves and assist the babies by doing the delayed cord clamping till we get these kind of babies who they will do the physiological cord clamping by their own self. So that means they will get to know, now I need to clamp the cord. And if you do the delayed cord clamping, those babies are much more intelligent and developmentally much ahead as compared to the babies in whom we do not do the cord clamping. The modern babies, future babies are these. So till we get these kind of babies, we have to do delayed cord clamping by ourselves. Thank you very much. If you have any questions, you can ask.